Welcome back to This Emergency Life. I'm your host, Kevin LaMonica. In today's episode, we're diving into a silent killer that often masquerades as something benign until it's too late: the abdominal aortic aneurysm, or AAA. Picture this. It's the middle of the night, and a 73-year-old man with a history of hypertension ambles into your emergency department. He complains of new-onset lower abdominal pain that jolted him awake. He's diaphoretic, but otherwise mentating normally. The triage nurse clocks him as ESI level 3. Perhaps he's got a muscular strain or a passing kidney stone, but while he's waiting to be roomed, he suddenly decompensates. Vital signs plunge, and you notice a telltale bruise of Gray-Turner's sign across his flanks. In that instant, you realize you're not dealing with back strain or stones, you're dealing with a rupture. Let's unpack how we identify and manage this high-stakes scenario before it spirals out of control. Abdominal aortic aneurysms are more common than many clinicians realize. In men aged 50 to 85, ultrasound-based screening studies estimate a prevalence of around 1.4%. Risk factors include male sex, advanced age, particularly over 65, smoking history, hypertension, hyperlipidemia, and a family history of aneurysms. Interestingly, while women account for only about 20% of all AAAs, they carry nearly 1/3 of the death toll from ruptures, often because they present later or are underscreened. Overall, rupture mortality hovers around 85–90%. Of the patients who actually make it alive to the hospital, only about 50–70% ultimately survive to discharge. The door swings open at 0300 hours, and our patient ambles in. He's a thin, hypertensive gentleman in his early 70s. He describes a dull, aching lower abdominal pain that started an hour ago and woke him up. No radiation to the back, groin, or legs, just a cramp-like ache. He denies trauma and reports no recent exertion. He appears uncomfortable but hemodynamically stable. BP is 138/82, heart rate is 96, respiratory rate is 18, pulse oximetry is 98% on room air. The triage RN considers musculoskeletal strain or possibly a ureterolithiasis, especially since flank pain is so common at this hour, and assigns an ESI level 3. Fast forward 30 minutes. Our patient has been brought back to the main ED pod, still awaiting imaging. Suddenly, he becomes diaphoretic and pale. His blood pressure crashes to 80/50, heart rate spikes to 130, and he starts clutching his abdomen. As we roll him onto the monitored bed, you notice subtle ecchymoses creeping across his flanks. Gray-Turner's sign. A late clue to retroperitoneal hemorrhage. That sign alone raises the alarm for a ruptured AAA. A ruptured AAA is a diagnosis you cannot afford to miss. Classic teaching describes the triad: acute abdominal or back pain, hypotension, and a pulsatile abdominal mass. But in reality, fewer than 60% of patients exhibit all three. Many will present with nonspecific pain or even subtle findings like flank ecchymoses or back discomfort. In unstable patients, especially elderly hypertensives, keep AAA high on your differential if they have unexplained hypotension, especially if paired with abdominal or back pain. Pitfall: don't dismiss lower abdominal pain in an elderly patient with hypertension because it seems mild or non-localizing. Even before rupture, expansion can feel like vague discomfort. When an elderly hypertensive patient collapses with abdominal pain and hypotension, think broadly. Ruptured AAA, Hodge, top priority. Aortic dissection extending into the abdominal aorta, massive mesenteric ischemia, perforated viscus, e.g. perforated ulcer, acute pancreatitis if retroperitoneal bleeding causing flank pain, kidney stones, although stones rarely cause frank hypotension without other clues, abdominal aortic occlusion like a thrombosis. Out of all these, a ruptured AAA kills fastest. Survival drops by about 1% per minute without intervention, so push it to the top until you can rule it out. In hemodynamically unstable patients, we may have to skip the CT scan or at least defer it. Grab your ultrasound probe and head to the bedside. A quick, focused aortic ultrasound cut can identify a dilated infrarenal aorta. Anything over 3.0 centimeters is aneurysmal. In the right clinical setting, unstable vitals plus free fluid, assume rupture until proven otherwise. That means if you see an aorta measuring, say, 6 centimeters with adjacent fluid, you don't wait for confirmatory CT, you mobilize the surgical team. But if your patient is still reasonably stable, mental status intact, systolic blood pressure is above 80, and you have rapid access to CT angiography, that can help plan whether open repair or endovascular aneurysm repair, EVAR, is feasible. CT angiography gives you information on aneurysm morphology, involvement of renal or iliac arteries, and presence of retroperitoneal hematoma, crucial intel for the vascular surgeon. As soon as you suspect rupture, 2 large-bore IV lines must go in. Type and cross-match blood products. Permissive hypotension. Is the mantra, target a systolic blood pressure of 70 to 90 while keeping the patient conscious, enough to perfuse the brain but not so much as to dislodge any forming clots. Crystalloids are a no-go unless you're in profound shock without blood available. Dilutional coagulopathy and acidosis are real dangers. Instead, initiate a balanced blood product strategy, packed red blood cells and fresh frozen plasma in a 1.1 ratio. Consider placing an arterial line en route to the OR, but not at the cost of delaying surgical intervention. Fentanyl is our go-to analgesic. Give 0.251 microgram per kilogram IV every 15 to 60 minutes to keep him comfortable without tanking the blood pressure. Don't intubate unless you absolutely have to. Induction agents can precipitate cardiovascular collapse. Once you confirm or strongly suspect rupture, call vascular surgery. If you're in a community ED without in-house vascular capabilities, pack him up and initiate transfer, ideally with a goal of getting him to the OR within 90 minutes of arrival. Remember, mortality climbs with every passing minute. Keep the anesthesiology team in the loop. Avoid long-acting sedatives and vasodilators. For those centers with hybrid OR capabilities, expedite coordination. Inform your team whether this is likely an EVAR candidate or an open repair. In our scenario, bedside ultrasound reveals a 6.5 centimeter infrarenal aneurysm with a surrounding retroperitoneal hematoma. He's crashing fast, systolic blood pressure of 70, heart rate 140. We call the on-call vascular surgeon, mobilize 2 units of uncross-matched O-negative blood, and start a massive transfusion protocol. An arterial line goes in as we roll him to CT, but the scan is brief. No aortic valve fistula, no significant iliac involvement. This is an ideal endovascular target. He's taken straight into the hybrid OR suite, where interventional radiology deploys a bifurcated stent graft under local anesthesia and light sedation. Within 45 minutes of arrival, the aneurysm is excluded, bleeding stops, and his vital signs stabilize. He spends 3 days in the ICU, weaning pressors, and by day 5, he's ambulating in a step-down unit. His post-operative course is uncomplicated. At 3 months, follow-up CT shows no endoleak, and he's off antihypertensives. His blood pressure is well controlled with lifestyle modifications. So what are the key takeaways? 1. Think AAA early in elderly hypertensives with unexplained abdominal and/or back pain, even if they appear stable at first. 2. Gray-Turner's and Cullen's signs are late but ominous clues for retroperitoneal hemorrhage. Don't wait for classic triad. 3. Rapid bedside ultrasound is your best friend in the unstable patient. Look for an aortic diameter, 3 centimeter plus free fluid, and presume rupture. 4. Permissive hypotension. Keeping the systolic blood pressure between 70-90 with balanced transfusion, 1:1:1, or use of whole blood products is key to preventing exsanguination. 5. Avoid intubation and excessive crystalloid. They can precipitate fatal hypotension and dilutional coagulopathy. 6. Activate vascular surgery immediately. Time to or 90 minutes is critical. Survival drops precipitously after that window. 7. EVAR under local anesthesia is preferred when feasible, less physiologic insult than open repair. Thanks for joining us on This Emergency Life. If you found value in today's discussion, subscribe, like, share, comment, and tell your colleagues. Next week, we'll tackle another high-stakes case. Until then, stay vigilant, keep your ultrasound probe handy, and remember, in the ED, complacency kills. I'm Kevin LaMonica. We'll see you on your next shift. Stay safe out there.